Welcome to the EFAS ultrasound training module. The FAST exam is a point-of-care ultrasound exam that was developed to evaluate trauma patients who are hemodynamically unstable and cannot undergo immediate CT imaging. It has been used to evaluate for intrathoracic and intraperitoneal free fluid. The FAST exam, or focus assessment with sonography for trauma, evaluates the intrathoracic and intraperitoneal spaces with 4 views: the subxiphoid or cardiac, right upper quadrant, left upper quadrant, and pelvic. The EFAST or extended FAST exam includes examination of the pleural spaces in addition to the previously mentioned 4 views to evaluate for pneumothorax and hemothorax. It is important to recognize the indications and contraindications for performing these exams in an emergency setting. The indications for an EFAST exam include blunt or penetrating trauma to the abdomen or chest, a pregnant patient in the trauma bay, and any time a patient suddenly becomes hypotensive. If you have unexplained hypotension, you can use the EFAST exam to help guide the next therapy. There are no contraindications to performing an EFAST exam, and there are various benefits. Ultrasound is easily accessible in the trauma bay, inexpensive, and non-invasive. While not as accurate as a CT scan, an EFAST exam is widely considered the best initial screening modality in trauma over DPL and physical examination. However, there are still limitations to the exam. One thing to keep in mind is that the EFAST exam has only about an 85% sensitivity to pick up any amount of free fluid in the abdomen. When the EFAST does find intra-abdominal fluid, it cannot localize the bleeding to a particular injury. It can also be limited by severe obesity, subcutaneous emphysema, or intra-abdominal free air. Additionally, it cannot detect all intra-abdominal injuries, particularly ones that do not cause accumulation of intra-abdominal free fluid. First, we will be looking at the right upper quadrant. Here, we are looking in the right upper quadrant between the liver and kidney, with the indicator pointing towards the head. This is known as Morison's pouch. The liver takes up almost the entire right upper quadrant of the abdomen and much of the epigastrum. Superiorly, the liver reaches the dome of the diaphragm, and posteriorly, it abuts the lumbar region of the posterior abdominal wall. The liver lies to the anatomic right of the stomach and overlies the gallbladder. The superior, anterior, and parts of the posterior surfaces of the liver are covered by the diaphragm. The inferior surfaces of the liver is not in contact with the diaphragm and overlies abdominal organs. The liver moves in concert with the diaphragm during inspiration. The liver is the largest parenchymal organ in the body, and due to its high fluid content and homogeneous nature, it serves as a useful sonographic acoustic window for imaging upper abdominal and retroperitoneal anatomy. The liver is an intraperitoneal organ. Now, moving on to technique and what it looks like to have a positive right upper quadrant view. With the indicator towards the patient's head, place the probe at about the 10th intercostal space. Slide the probe superior and inferior and fan the probe anterior and posterior in order to see all the way through the interface of the liver and the kidney. Now, it's not just a static window, but you really do need to fan anteriorly and posteriorly, getting through all potential windows of that Morison's pouch. The hepatorenal window, or Morison's pouch, is the interface of the liver on the kidney. Now, this is the most dependent portion of the peritoneal cavity. So in a patient who is supine, this is the most likely site you will find blood. And this is what it looks like when it's positive. We have the liver, we have the kidney, and you can see some anechoic fluid, the sharp angle layering out between the liver and the kidney. This is a positive EFAS with fluid in the Morison's pouch. Then we move on to the heart. There are 2 views of the heart. One where you look in a subxiphoid or subcostal view, or underneath the sternum with the indicator towards the patient's right, and the other one when you're looking parasternally or in that 3rd or 4th intercostal space with the indicator towards the patient's left hip. We will be focusing on obtaining the subxiphoid, aka the subcostal view. The heart is surrounded by the bony sternum and air-filled lungs. Neither bone nor gas permit effective transmission of ultrasound waves. So to effectively obtain images, one needs to aim the ultrasound beam into the spaces between the ribs to avoid bone and gas. These spaces are known as echocardiac windows. The subxiphoid view of the heart is obtained with the patient in a supine position with the knees slightly bent. The transducer should be placed just below the xiphoid process at a 15 to 30 degree angle to the skin. The ultrasound beam is pointed towards the patient's anatomic left shoulder. The transducer indicator is pointed to the patient's anatomic right flank. Asking the patient to breathe deeply will cause the diaphragm and the heart to drop lower in the chest, improving subxiphoid image quality in many patients. One will often need to apply compression to the probe to obtain an optimal image window. The beam emanating from the ultrasound transducer is typically directed at the patient's left shoulder. However, the exact optimal position varies greatly. The liver is a key acoustic window, and it is helpful to find the liver first by angling the ultrasound beam towards the right upper quadrant and then following the liver to the patient's anatomic left and finding the heart. So this is a 4-chamber view of the heart. We can see the right atrium, the right ventricle, left atrium, and left ventricle. We can also see the interventricular septum here. The pericardium can be traced around the heart here, around the apex, and then finally posteriorly. And on this still image, I don't see any evidence of a pericardial effusion. But over here, on this moving image, we can trace out the pericardial effusion around the apex and posteriorly. And this patient does indeed have a pericardial effusion. Approximately 50 milliliters of pericardial fluid is required to identify a positive FAST in the cardiac window. Signs of cardiac tamponade include right atrial systolic collapse and right ventricle diastolic collapse. Next, we will be examining the left upper quadrant. The left upper quadrant is used to screen for fluid in the splenorenal interface. It is also used to screen for pleural fluid, such as hemothorax, subdiaphragmatic fluid, and used to visualize direct evidence of splenic or renal injury. The spleen is a bean-shaped lymphatic organ that is located in the posterior lateral aspect of the left upper quadrant of the abdominal cavity. The spleen is typically located just lateral to the stomach. The spleen sits deep to the 9th through 11th ribs along the left lower chest. The diaphragm is located just cephalad and posterior to the spleen. The normal adult spleen is entirely within the peritoneal cavity. In order to obtain an adequate splenorenal view, we will once again point the indicator towards the patient's head, then position the transducer over the 10th intercostal space. Then, with the indicator towards the head, slide the probe superiorly and inferiorly to get the entire contents of the splenorenal window into view and fan anteriorly and posteriorly to get the optimal window. One must obtain a very posterior view in order to visualize the spleen and kidney coming in contact with each other. Both the spleen and the kidney should be seen on the screen at the same time and avoid imaging the stomach. What we are seeing in the recording here is a positive left upper quadrant view. There is free fluid between the spleen and the kidney. There is the anechoic free fluid seen here. On the right are also 2 examples of free fluid in the splenorenal space. It is also important to remember that the most common area to find free fluid in the left upper quadrant is in the perisplenic space, as the splenorenal ligament that attaches the spleen to the kidney prevents a significant amount of free fluid from accumulating between the kidney and the spleen. When looking for free fluid in the pelvis, it's important to consider your patient's gender, as free fluid has a tendency to accumulate in different locations. Additionally, females may have a scant amount of normal physiologic fluid accumulation in the pelvis and the pouch of Douglas. The rectovesical pouch is where free fluid will accumulate in male pelvis, and in females, the pouch of Douglas is where fluid will accumulate. There are 2 standard ultrasound views of the bladder. There's the transverse view and the sagittal view. In the transverse view, the indicator is pointed towards the patient's anatomic right, whereas in the sagittal view, the indicator is pointed to the patient's head. But note, in either view, one needs to fan or rock the transducer and aim the sound inferiorly in order to see all the way down the pubic symphysis where the bladder lies. Ideally, scan your patient with a full bladder so that the bladder can be used as an acoustic window. Therefore, try to initiate the scan prior to Foley catheter insertion. One of the most important things to remember when performing a pelvic ultrasound in an EFAST exam is that the bladder is directly posterior to the pubic symphysis/bone. If you're unable to get proper images, most likely your ultrasound probe is placed too superiorly. In this recording, we can see an anechoic wedge of free fluid adjacent to a full bladder. On the right are two other examples of free fluid in the pelvis adjacent to the bladder. The lung ultrasound exam is started along the anterior chest in the second or third intercostal space and descends caudally in a systemic fashion as needed. This initial starting position enables evaluation of the upper lung fields, which is the least gravitationally dependent area of the inner hemithorax. Moving the probe inferiorly will enable scanning of the lower anterior lung down to the diaphragm. The transducer will need to be moved, rotated, and angled to ensure one gets a good lung window. The probe is positioned on the chest wall perpendicular to two adjacent ribs with the probe indicator pointing cephalad, or pointed to the patient's head. The ribs create acoustic shadows that serve as borders for the image window. The lungs and the inside of the thoracic cavity have a pleural lining. As the lungs expand, the visceral and parietal pleural surfaces slide past each other. The fluid between the two surfaces acts as a lubricant to allow lung expansion during inspiration. The direction of the sliding of the visceral and pleural lines is then reversed at expiration when the lung returns to normal end expiratory volume. This to and fro motion is detected by ultrasound and described as the sliding lung sign. Lung ultrasound is heavily dependent on the interpretation of lung imaging artifacts and sonographic signs. Normally, ultrasound signal is blocked at the pleural line by the underlying gas. Following lung injury that extends to the pleural margin, injured lung tissue develops the ability to transmit image artifacts as a result of gas and fluid interactions within the lung tissue beneath the transducer. These signs and artifacts are used typically in combination to identify normal lungs, to rule in or rule out pneumothorax, and to identify pleural effusions, lung consolidation, and acute interstitial syndromes of the lung. However, during this demonstration, we will focus mostly on the pleura for the evaluation of a pneumothorax. Here we are demonstrating what normal lungs look like on ultrasound. We will be focusing primarily on the sliding lung sign. In this clip, we can see clear evidence of lung sliding, or the sliding lung sign, indicative of normal lung physiology. The arrow in the first image shows the interface of the pleural lines. Importantly, the lung sliding rate should correlate with a patient's breathing rate. This is true regardless of whether or not the patient is spontaneously breathing or is receiving assisted positive pressure ventilation, such as an intubated patient. When performing an EFAST exam, attempt to identify the sliding lung sign at that location and then move the transducer inferiorly along the anterior chest. Ideally, one will scan along the entirety of the anterior thoracic cavity and be able to document lung sliding at each point, supporting the absence of a pneumothorax. If the sliding lung sign is absent, move the transducer in a posterior lateral direction along the same rib space and attempt to identify a sliding lung sign. The absence of a sliding lung sign supports the presence of a pneumothorax. Again, this is not necessary if lung sliding is initially seen at the location scanned, such as the anterior chest. Trace the relative size and margins of a pneumothorax by identifying the locations at which the sliding lung sign is present and the sites at which it is absent. The accompanying ultrasound video demonstrates a lung pause on the left and lung sliding on the right. Notice the shimmering movement timed with the patient's heart rate on the left as compared to the obvious sliding of the pleura in the right image. There is little doubt that there is significant sliding back and forth across the screen. The long point is the intersection between the lung moving against the inner chest wall and the pneumothorax. The lung point has been defined as the transition point of a lung pattern to a pneumothorax at a precise location of the chest wall. This can be seen in the accompanying ultrasound image. The lung point is virtually pathognomonic and therefore the most reliable sonographic finding for a pneumothorax. Documenting a lung point rules in a pneumothorax. Tracing the lung point across the chest wall using ultrasound helps one delineate the margins and evolution of a pneumothorax. Note, absence of a lung point does not rule out a pneumothorax. To summarize, the FAST exam is comprised of 4 main windows: the hepatorenal window, or the right upper quadrant, the cardiac window, which is really 2 views of the heart, a subxiphoid or subcostal view, and a peristernal long view, a splenorenal window, or left upper quadrant, and a suprapubic window. The EFAST exam is an extension of the FAST exam and involves evaluating the right and left hemithoraces for pneumothorax. Key points to remember include the following. Pericardial, peritoneal, and pleural free fluid can be reliably detected with an EFAST exam. An EFAST exam is best at evaluating dependent peritoneal spaces, pleural spaces, and the pericardium. While performing an EFAST exam, make sure that patient is in the proper position, which includes lying supine on a flat examination table or in the Trendelenburg position. And lastly, remember that 600 milliliters of free fluid in the abdomen and 50 milliliters of pericardial fluid in the pericardium are required for a positive EFAST exam.